Welcome. Hi, I'm Mikki, and this is Mikkipedia, where I sit down and chat to doctors, professors, athletes, practitioners, and experts in their fields related to health, nutrition, fitness, and well-being. And I'm delighted that you're here.
Hey everyone, it's Mikki here, and this week on the podcast, I speak to Dr Jeffry Gerber, Denver's diet doctor, about diabetes, surprising findings when measuring insulin levels in his patients, educating both practitioners and the general population about the importance of eating quality food, and how his nutritional advice has changed over the years. Dr. Gerber is the co-organiser of Low Carb Denver and Low Carb conferences and has spent several years learning about the impact that diet and lifestyle has on improving metabolic health as a family physician. And he uses the conference as a platform to help inform and educate from the grassroots level. Jeffry is also the co-author of Eat Rich, Live Long, a book that provides simple guidelines and delicious recipes that help people adopt a lower carbohydrate diet approach. Jeffry and I have known each other for several years now, having met at the Ancestral Health Symposium back at Berkeley, I believe, in 2014. And since then, I've really looked up to him in terms of his knowledge and understanding of a low carb approach, but also how that has evolved based on his patients and also just as all of our information and education evolves over the years. So Dr. Jeffry Gerber is a board-certified family physician, speaker, author, conference organizer, husband, father, and owner of South Suburban Family Medicine in Littleton, Colorado, where he is known as Denver's diet doctor. He has been providing personalised healthcare since 1990 and continues that tradition with an emphasis on longevity, wellness, and prevention. And Jeffry and I also talk about mitochondrial health and, interestingly, altitude and just the importance of fat utilisation there. Dr. Gerber is also the co-organiser of Low Carb Conferences, a yearly educational event for healthcare professionals and anyone else interested in learning about the latest science related to diet and health. And we also, of course, discuss this because I'm headed to Denver next month to attend the conference, and it is just such a great way to connect with like-minded individuals. And these, even people who are up to the play with the latest research can really benefit from attending this both virtually or in person because you just learn so much. And that conference is running 23rd to the 26th of February, and I've included links to both of those in the show notes today, and also links to how to connect with Jeffry over at denversdietdoctor.com. I'd like to remind you the best way to support Mikkipedia is to hit the subscribe button on your favourite podcast listening platform. That increases the visibility of Mikkipedia in amongst the thousands of other podcasts out there. And this benefits the podcast and, of course, the new people who can then have access to the information that my guests bring to the podcast, which I'm so grateful for. You could also leave a 5-star review if you felt like it. They'll be amazing. All right, team, enjoy the conversation I have with Dr. Jeffry Gerber. Dr. Jeffry Gerber, it's lovely to have the opportunity to chat to you today. Thank you so much for taking the time.
Yeah, it's great to be here, Mikki, and I know we saw each other a few months ago in California.
Yes, we did. And excitingly, we'll see each other again in about 6 weeks' time at Low Carb Denver, which is fast happening upon us. And of course, I want to chat to you about that as well today. But first, Jeff, if it's all right with you, can you give us a little bit of your background, please, and how start with your background, and then we'll sort of go from there.
Yeah, sure, Mikki. Well, hello to your audience. I was in New Zealand visiting you. It was actually 2016, a long, long time ago. But over the years, you've traveled with your friends and colleagues to the U.S., and we've bumped into you on several occasions. But about myself, I'm a family doctor, and I go back about 30 plus years at this point. I mean, almost 35 years. And my interest in nutrition is now over 20, almost 25 years old. So yeah, I come from a family of doctors. You could say it was in our genes, but
Yeah.
also had an interest in nutrition and weight loss because we were all overweight growing up, and the family were always trying to do this, that, and the other thing back in the 60s and 70s. And I have to credit my mother, who piqued my interest in medicine and health and nutrition. And the other aspect about myself is that I've always been an independent thinker and uh, looking outside the box, not necessarily drinking the Kool-Aid, but wondering about how things work, how we can fix them, how we can make it better. And so, I headed off into the medical school, and in medical school, I learned how to be a doctor, very good at diagnosing, prescribing, and treating, but not learning much about nutrition other than the standard advice to eat less and exercise more, and learned that was really unsuccessful in terms of helping our patients achieve goals in terms of weight, health, and so forth. And patients, around 10 years into my being a doctor, would come to me and they were trying these crazy low carb diets. And my father-in-law lost a lot of weight doing Atkins, and he challenged me, and I lost 40 pounds right away.
Oh my
It's
goodness.
it's really a classic. Go ahead.
Was that when your father-in-law was doing it, Jeff? Was it, had you begun sort of exploring the area, or was he one of your first sort of introductions to it? Him and your patients?
Yeah, he was one of the. Again, it was in my family. I had known about it, but he put the challenge out that he had picked up an Atkins book, and he rapidly lost weight, and then he challenged me, and at this point I had said, well, you're all going to drop dead, your hearts are going to explode from eating all the the saturated fat. And so, but again, I as an independent thinker, I was open to the idea, and I actually was, have been following my patients at this point, and their hearts didn't explode. They actually lost weight, and they felt better, and their metabolic markers improved. And so for myself, I rapidly lost 40 pounds, and I felt great.
Yeah.
And I said, wow, there's something to this. And I started to do my research, to read about it, look at the literature, and the light bulb went off in the head. And I said, I think we got nutrition wrong. And so really, from that point forward, I've continued as a family doctor, and we call it primary prevention, and doing primary prevention properly, which is approaching nutrition in a way that will really help our patients and prevent disease. And so that's what we've been doing for the last 25 years, and it's really been fun and successful. We went out on the lecture circuit. We wrote a book with Ivor Cummins several years back. And then we started doing conferences back in 2016, and our sixth one is coming up. And I've realized that, my passion is nutrition education.
Yeah, it's so interesting, Jeffrey. Like you've really taken that from the individual level and really sort of built a platform, if you like, through, of course, the book, but the conference and the speaking, your speaking engagements, and actually getting that message out there. And I'm always really interested to understand the genesis of where someone has sort of begun in this space. And obviously for you, your father-in-law. Were you delighted? Were you like, oh my goodness, I can eat bacon and eggs and lose weight? Was that how you felt? Like,
Yes, well, again, I've been on the weight loss diet yo-yo my whole entire life. And, for myself now, it's almost 25 years, and I've kept off most of the 40 pounds. And, it's I was probably insulin resistant back then, although I didn't test myself. And you know, just the one caveat is that I think that the dietary approach is different for the individual,
Yeah.
but in terms of an overall theme, I think cutting out processed foods, which are carbs and the industrial vegetable oils from the diet, are overall that really helps everybody. But for myself and others that are insulin resistant, really focusing on reducing carbohydrates
Yeah.
and increasing more protein and natural fats in the diet, it's just a natural way to control appetite, and it shifts the focus from telling individuals or for yourself you have to adhere and you have to deprive yourself of things in life that you enjoy, where we're switching over to mindful living, trying to find foods that satiate, and we enjoy the food and we enjoy the life. And if it's working right, we're not as hungry and we're going to end up eating less and improving our health.
Yeah, I find it really interesting, Jeffrey, that one of the biggest contentions, if you like, is, or that you hear, or people hear, is that low carb diet, it's unsustainable. People don't adhere to a low carb diet. Whereas I actually feel like, as you've described, when you find foods that naturally allow you to feel satisfied, it's so much easier to adhere. So I always question, who are you actually asking about the adherence if it's not the people that are actually doing it and successfully sort of implementing it for many, many years? Like, I don't know, like, what are some of the things that you hear out there about the low carb approach with respect to sort of common beliefs or misconceptions, which to be untrue?
Yeah, well, look, we have anecdote after anecdote of patients that have really had success and have been able to do this long term. So that it's not sustainable. That's a misconception. That it's going to that you're going to have a heart attack and drop dead from eating all the saturated fat. That animal protein and red meat is going to cause cancer. It's going to cause kidney problems. It's going to cause problems with gallbladder, and the list just goes on and on. And so, first of all, when you look at each and every one of those misconceptions, and you actually look at the evidence to support, there really isn't. And in fact, it's been 25 years. And look, I don't do research, but I call them anecdotes. But there's one after the other. And so, not everyone can have success. And again, there's different approaches, and we don't give the same advice to individuals, but again, we provide tools to help patients, and we're kind of changing the lens and the discussion about looking at food in a healthy way.
Yeah, totally, Jeffrey. And obviously, you've been doing this for 25 years, and you're well known, Denver's diet doctor. How was it when you first sort of started implementing this in your practice? How was that taken by your colleagues?
Yeah, that's a great question, Mikki. So, this was back in the year Y2K.
Oh, wow.
Yeah, really. That's when
Yeah.
that's when it really started for me. And there wasn't much internet, and I have some gray hair, and the others with gray hair include Eric Westman and Gary Taubes, and Steve Finney goes back even before us. But and then there was Jackie Eberstein, who was the nurse who worked with Robert Atkins. So there wasn't a lot of people back then, and so I feel like I had gone out on my own back
Yeah.
then. Into the great unknown. And I forged forward, and I was kind of cautious. I was kind of quiet about what I was doing with my patients, although some of the patients loved it. But my first correspondence was actually with Jackie Eberstein. And I reached out to her on email, and I was typing and my fingers were shaking because she was, I was like, this was a famous person. And and she's probably not going to respond back. But lo and behold, she responded back right away, and she was so personal and approachable. And and we've met in person, and this is the way it's really been in the low carb community moving forward. But as time has gone on, I've realized that I work with other doctors in our community. My office, and it's my own office. I'm a dying breed. I don't work for any system, which is kind of unique. But I work on a hospital campus, and my colleagues know what I do, and they really never made a bother about it. And you have to understand the temperament. I'm not a troublemaker. I'm more of finding middle ground. And, it takes all kinds in this community to advance nutrition science. And, as you know, we do have all kinds. And so I'm just trying to find middle ground. And again, I want to educate my fellow healthcare professionals about discussing better nutrition with their patients.
Yeah. Jeffrey, after 25 years, do you feel like the field or the public perception of this should have moved on a little bit more than it has? Or has the trajectory been as you might have expected?
I wish it would have moved on, but again, we're up against the healthcare authority.
Yes.
And advancing science, what's the expression?
One funeral at a time.
Yeah, one funeral at a time. That's exactly what I was going to say. And so, I'm just doing my part. So, one-to-one, healthcare professional to healthcare professional on social media, through our writings, our presentations, and now the conference. We wish that we could have every healthcare professional in Denver come to the conference. I mean, it's right in the backyard. But the problem is that most healthcare professionals are busy and they don't have the time or interest in discussing nutrition. That's the biggest frustration.
No, I appreciate that, because of course, a lot of people have, they tell me about their sort of interactions with their doctors, and they're like, I'm so frustrated with my doctors not listening, but actually that doctor has like 15 minutes to assess almost, everything and sort of come up with something, and they've got however many patients back to back for hours on end each day. There's not a lot of time to explore any additional interests. I'm often very, I find it's impressive that doctors do actually take the time to do research and stuff outside if it's a personal sort of passion of theirs, because otherwise it's so challenging.
Yeah, well, look, that's what we do. So when we have a patient visit, and I also want to mention that I really enjoy still working in the healthcare system, because, someone's got to be there to help the patients navigate the landmines of healthcare.
Yeah.
And so we're still working in the system. But, we take the time to discuss, nutrition with our patients. And there was another point I kind of forgot, but, we would certainly hope that the other healthcare professionals would take interest.
Yeah. And I feel, Jeffrey, that possibly change might come if there was room in the medical curriculum to allow for that education, like it's certainly from a grassroots approach that, you can reach a lot of the sort of population, but it's that curriculum I feel that would be amazing to be able to make change there.
Yeah. Along those lines, you reminded me that, we, as a healthcare professional, we were taught how to prescribe medication, but what we're doing is kind of bridging this gap between what we can do in modern medicine and what we can do in nutrition. And that includes deprescribing. And, that's a lot of fun. And I was actually looking at my medical school yearbook.
Yep.
Okay. This is like from 30 plus years ago, right? 35 years ago. And there's a picture of our health and prevention class, and the joke was there was nobody in the lecture hall.
Oh.
it was empty. Now, we had a guy that took notes. There was one guy that would take notes.
Yeah.
But the point is that nobody cared about prevention. And, so it does need to change in, in medical school, that there really should be a curriculum that's devoted to proper prevention and nutrition.
Yeah, yeah. And as you say, that's up against it a little bit in light of the powers that be above that, I suppose.
Yeah,
Yeah.
exactly.
So Jeffrey, with regards to what people get from a clinic like yours, because I think it's really interesting for the audience to understand maybe what the process is if people were to come and see you, because I don't know how many clinics. I don't think there are particularly that many clinics really set up doing what you do. So I think it's really interesting to chat about what people would get. Yeah.
Yeah, well, first and foremost is that we're a family doctor, or a GP, as you would say, and we work with under the constraints of commercial insurance. And, we also have, the socialized insurance. I know in your country, Medicare is the term for all of the socialized policy. We call Medicare in this country for elderly, but then we have Medicaid. So, we work on insurance. We do cash. And so we see patients just like we see any other patients for initial evaluation, general checkup, physicals, health and well-being. But they're forewarned that we are going to discuss nutrition with them. Some of them come and seek us out because of our interest in nutrition, and they have health concerns such as weight loss, diabetes, heart disease, which are the big three. And I have a particular interest in longevity and cardiovascular risk. And so it's just a general checkup, and then from there, usually if a patient wants to address a weight issue, we will schedule them on their next visit for a glucose tolerance test. And the insulin assay. So Joseph Kraft and your colleague Catherine Crofts has done a lot of work on the on the Kraft data, and she actually came up with a simple tool to measure 2-hour insulin after a glucose challenge. So we've done thousands of them.
Oh, amazing.
And yeah, over the years, and there's some interesting findings. That the first finding that's really interesting is that in terms of screening individuals for diabetes and prediabetes, this is where the glucose tolerance test and the insulin assay comes in. And so you can see an individual, and they can be any shape and size. They could be normal weight, overweight. We have Asian population that are what we call TOFI, thin on the outside, fat on the inside, where they appear healthy, but they're metabolically unhealthy inside. And so there, in some individuals, the fasting blood work looks pretty good until you do the glucose challenge, and you might see glucose shoot up high or not. But then the 2-hour insulin is interesting. Everything else looks okay. There's some signs that there's something going on, but the 2-hour insulin can be off the charts. So over 40, we call that abnormal if in the 2-hour insulin assay. So we think that addressing insulin resistance early on can be so powerful, because it can set in 25 years before you become overtly diabetic.
So Jeffrey, I find this so interesting, because when people go to get blood tests here in New Zealand, and I understand it's the same maybe where you are, where we get a fasting glucose, we get HbA1c or A1c, we get that measured, and then of course the cholesterol panel that tells us the triglycerides, which there is a relationship there. Why? And I've always wondered. Well, not always, maybe over the last 10 years, why insulin isn't routinely measured, given that that's almost like the prequel, if you like, to everything else that happens afterwards. Like, what is it that doesn't make that just a standard?
Yeah, well, you answered it, that it's not the standard of care. And, in addition to the things that you mentioned, which is great. I think basic testing is fantastic. You could, you look at the triglyceride to HDL ratio, you can look at glucose HbA1c, and you can get a really good idea as to what's going on with the patient. But we're able to get fasting insulin and also C-peptide, which is a measurement of the pre-insulin, or a pro-insulin measurement. And I've had an endocrinologist come back at me, Gerber, why are you measuring insulin levels? And why did you do a glucose tolerance test? And why did you measure a 2-hour insulin? And, it's just because it's not the standard of care. But, what we're doing really has a powerful impact in our patient's health long term, because we're able to recognize something very early on.
Yeah. And Jeffrey, I don't know if you'd be able to speak to the sort of New Zealand or Australian environment. Those tests that you routinely run, can anyone ask their doctor to be screened like that? Or are they sort of special stuff that actually only some people are able to get a hold of?
Yeah, well, here, the patient can request blood tests from their doctor. Whether the doctor's going to agree to do it or not is another thing. And so, we've had patients that want to do fasting insulin and they want to do advanced lipid testing, and there are other doctors that are like, what do you want to do that for? Now, I know in New Zealand and Australia, you may have some restrictions in terms of what you can and cannot do, if I'm correct.
Yeah, that is correct.
So, in our country, I don't have a problem. The idea is that to work within the healthcare insurance system, if you simply code for the comorbidities, whatever, if a patient has obesity or diabetes, prediabetes, heart disease, hypertension, kidney disease, you use comorbidities, and then in general the insurance will pay for testing. However, you have to be careful. There are some nuanced testings, like patients want to come in and they want to do a complete genetic profile, or they want to look for heavy metals and chelation, and that really takes us into the field of functional medicine or gut health. They want to look at the microbiome. I'm interested in all that stuff, but I just have to tell individuals that there are some constraints to what can be done through their insurance, and in our country they can go out on their own and get all the testing they want.
Yeah, no, that's awesome. Obviously, you've got a special interest in longevity and wellness and things like that. What's the next sort of step once you get those results?
Yeah, well, just to mention briefly on the other side of this, that when we do glucose and insulin, we have some patients that are not at ideal body weight, or they have some health issues, and we do insulin testing and it's normal.
Yeah, interesting.
And yeah, so it's actually it's a fair share of the female population. I would say it's almost a third or more of the female population. Women who come in are not at their ideal body weight, and their metabolic testing is normal. And so, the point there is, so what are you going to do with them? And the approach is different. And so, like I mentioned early on, we do our workup, and if we have the insulin resistant patient, so initially a low carb, high fat diet really works well. And the basic mechanism is that insulin is driven predominantly by carbohydrate, less so from protein and fat in the diet, and so it helps to improve blood sugar, and it helps to control appetite long term for those individuals. But if you have someone who's more insulin sensitive, you can put them on a high fat diet, and you'll certainly satiate them, and they may lose a few pounds, but long term, they're not going to have success, and the weight's going to rapidly come back, and they're going to be frustrated. And so this is where the mindfulness comes into it, and it's very important to talk to patients that are both insulin sensitive and insulin resistant, but in particular these insulin sensitive, they measure normal. That the goal is to always focus on finding a mix of macronutrients, a mix of micronutrients that are going to satiate, control appetite, so you're not hungry and you eat less. Mindfulness, where you're paying attention to your body. You're trying to restore, central satiety signals rather than, your stomach just expanding from bloating from carbohydrate. And so, this is where the approach is different. And I should say that if you have a diabetic, clearly a ketogenic diet should be the default diet for them.
Yeah, 100%.
I mean, it's just been shown over and again. But as they improve their metabolic health and lose weight, and they become fat adapted, well, guess what? Their diet's going to look very similar to somebody that's doing long term that's insulin sensitive.
Yeah.
And that is, we kind of use the term low carb Mediterranean, where the long-term approach is that you don't want to gorge on fat, where you just fill with fat, because again, fat is caloric dense. Fat is also, it has some nutrient in it, but not a lot of nutrient. So you eat enough fat to fill. And Ben Bickman, I love his alliteration, where you eat enough fat to fill. But if you do that by eating lean cuts and fatty cuts of meat, not pouring butter or olive oil or eating bacon all day long. So you do that part, and if you're doing that right, then you're going to be increasing your protein and lean protein, and we really prefer animal sources. And then the carbohydrate intake will be varied. And again, to say protein is really where all the micronutrients are, and protein is like the building block for the body. And Dr. Einfeld, I have to give him credit. He kind of calls, protein like builds the engine, and then you have the fat and the carbohydrate to fuel the engine.
Yeah.
And you got to get the mix and the micronutrients right.
Yeah. No, that's great, Jeffrey. And actually just a couple of points on what you just mentioned or just talked about. So with regards to the woman, a third of the women being insulin sensitive, I find that super interesting, because that's so in line with my clinical practice, where women come in overweight, wanting to do a ketogenic diet, or come to me because they have been doing a ketogenic diet, yet it's no longer working for them. And I see that time and again. And so these, like my predominant approach is a higher protein, lowish carb, but also lowish fat as well for these people, because for a lot of people, that's where that sort of sweet spot is. But to have that aligned with what you're seeing in blood work is super interesting, because we don't always have that intel, due to the fact that we don't get those measures of sort of insulin resistance and stuff like that.
Yeah. So look, working in the trenches, as we like to say, you and myself, the perspective is you have to deal with this. And so, we're also out on social media, but, my message isn't, a hard sell in terms of creating it like a false dichotomy.
Yes.
And Lane Norton, actually, I have to give him credit for this false dichotomy where, it's calories against hormones.
Yeah, I know.
Right? Calories against, but they're all, the point is, at the end of the day, it's all important. So, it may be a boring message, but what we're trying to do is improve people's health. I'm not trying to increase my following on social media.
No, totally. And so, Jeffrey, how does that play into the markers or the measures that you look at from a longevity perspective? Obviously, it's a big part of it. So what other things do people sort of come to you for or get from that perspective?
Yeah, sure. So look, we want to measure all the basic numbers that you had mentioned. We want to look at thyroid. We want to look at kidney, electrolytes, liver function. And, another tool that we really like to look at is heart calcium scores long term, because that's one of the longevity factors. And so, often a low carb diet will elevate the LDL cholesterol, although it improves the ratios in a good way. LDL can go up in some. And so, as you know, that's always been a big contentious issue, that, and I mentioned in the beginning that, this diet is perhaps, a misconception that it's unhealthy for your heart. And so the heart calcium score directly visualizes the coronary arteries. So it's a CAT scan. It takes 10 minutes. It's only $99 here in the US. And it looks for the buildup of calcium, which is really the tip of the iceberg in the arteries, and there's soft plaque underlying. But, a 0 score is a perfect score. A higher score increases your risk of disease. It doesn't look for blockage, and that's really important for people to understand it. It just measures the overall burden of plaque and gives you a number. You really need to do like a heart catheterization or a CT angiogram to see if there's blockage. So it's a great screening tool, and it looks at the health of the engine, the heart. The blood markers is a great analogy. Is really looking at the fuel. So you have different tools, and so what's interesting is often a heart calcium score doesn't correlate with LDL cholesterol. And so it's just fascinating. So you can do heart calcium scores and you can follow them serially. Although, again, heart calcium scores, a lot of healthcare professionals don't even know about them. And, if they do them and there's any calcium, they just want to put them on medication. And so, with all else being equal, and it's not equal. We're approaching this through diet and nutrition. It's not a test to tell people they have to take medication. Although if they have a higher score, we have that discussion, and it's not a segue to getting additional heart testing.
Yeah.
So yeah, that's how we approach it long term.
Yeah, Jeffrey, with a calcium score, can you do anything to reduce the calcium, or is it a matter of delaying the progression further? Is that how diet and nutrition work in that space?
Yeah, so when I look at the literature, I do not see that you can reduce a calcium score. So again, calcium and plaque is there to repair damage, and so in that sense, it's a good thing.
Yeah,
it's like the Golden Gate Bridge has cracks in it.
Yeah.
And the traffic's flowing, and we don't want the bridge to fall down. So, the mason goes out there with his cementer, and he patches up all the cracks, and he gets to the other side of the bridge, and he turns around, and the traffic's moving and the bridge is still standing. And so that's how the calcium score, or plaque, that's how we look at plaque, that it's repairing damage. And so, or it's like, it's a wound that's healed. And so the idea is that we want to see that it's stable. And, there's different ways to measure the score. There's a density and a volume. And so we look at the volume score, and volume over the years will tell you if there's new areas. So you can look at existing areas with density, and they can consolidate and actually get a little more calcium, and that it might be a good sign. It's still the experts are still researching and trying to decide what's stable plaque, what's unstable plaque. But if volume score increases, that's really a sign of progression. And so if we can see that the volume score stays the same in over the long haul, the risk of an event actually drops. So there's patients that have old stable calcium, just like the Golden Gate Bridge that I was giving you the analogy.
Yeah, okay. And so it's really a matter of looking at what might cause the damage that would then encourage that calcium deposition in the arteries, and trying to do the things you can lifestyle-wise to prevent that damage from occurring.
Correct. So the mechanism is that plaque atherosclerosis is an inflammatory disease, just like everything else that we've been talking about and dealing with. And so we want to look at, metabolic health, and, it's not about simply lowering LDL cholesterol, and, to think that the medications are going to, we give a statin, for instance, to a patient. Just take the statins, and you can go to any fast food restaurant you want and eat whatever you want, and you're going to live forever. I mean, it's just that's the wrong message. That's not how it works.
Yeah. And is that how a lot of people, like general population, is that how a lot of people sort of think?
Yes, I mean the commercials are designed that way on television, and when we look at the use of statins for primary prevention in terms of individuals that are free of heart disease, uh, you know, you don't live any longer, and it really doesn't reduce the event rate, despite what the whole industry is telling us. And so, this is where it was important for all of us, you and me both, to be thinking outside the box and to really ask these questions and to step back and say, hey, I tell the patients, look, you're going to take a statin for primary prevention. It's not going to help you. What's going to help you is diet and lifestyle.
Yeah, yeah. And Jeffrey, how does our mitochondrial health play into all of this? Like, is this on your mind as you're sort of addressing some of these things with your patients?
Yeah, well, thanks for bringing that up, Mikki, because both of us love to talk about mitochondrial health, and so. Just to make that for a really short discussion, is that I gave a great talk several years back. And so the question is, how do you fuel your mitochondria for longevity? And I like the expression, longevity is an endurance sport. And then how do you fuel that? And so if you look at oxidative stress in the mitochondria, and there's a lot of mechanisms, and the concept here simply is that that fat is really a slow burning fuel in the mitochondria, whereas glucose is like rocket fuel. And my talk was about literally heat generated by rapidly burning energy in the mitochondria, but there's reversed electron transport, there's mitohormesis, there's uncoupling, which is also the way that the mitochondria, actually like a heat sink, give off heat in a good way. Just they kind of dissipate heat. So it goes on. And so I think there's a lot of good mechanisms. It's mechanistic to make this argument that long term, you can use both fuels, but if you just stick with glucose your entire life, that your diet is predominantly glucose based, that you're going to be stressing mitochondria. And so, the argument is that fat as a slow burning fuel is good for longevity. The other aspect of this is it's good for athletic performance. And so, look, it's good to be fit and in shape. And when you're fit and in shape, you can oxidize both fuels. You can do both fuels. And I live up in altitude, and so there's this whole argument: what's the best fuel for the altitude? And some of the altitude enthusiasts say, well, glucose. It's glucose because you don't need as much oxygen to metabolize glucose at altitude. I mean, if you look at it on a molecular basis, that might be true, but it turns out that you might need less oxygen, but you give off more CO2 when you're using glucose as a fuel. And so what's the net effect on gas exchange or breathing, right? And so, the simple answer is that, if you're fit and in shape and you're able to metabolize fat, long term, at any altitude, you're going to be, again, doing quite well with fat as the predominant fuel. Now, just one other thing, fat, you have to have oxygen to metabolize it, and it's called oxidative phosphorylation in the mitochondria. But glucose, there's kind of two pathways. You can do it with oxygen or without oxygen through glycolysis. But the problem with glycolysis or fermentation is you give off lactate.
Yeah.
And, people that are not fit, their mitochondria don't work right. And so they're kind of starving for energy. And we have to give Mark Cucuzzella credit for this one.
Yeah. They're
starving for energy. And so they're really, they have to resort to glycolysis, and, they're burning glucose, and, they can't really exercise. So they have to get fit. And so that it's really an argument for being fit along with, diet. exercise, maintaining, musculoskeletal health, skeletal muscle health throughout life, increasing mitochondrial density. All this is important.
Yeah, totally. And Jeffrey, I think what this really allows people to appreciate is that it's not just about body size when we talk about using different fuel substrates and the importance of a quality diet, but potentially a lower carbohydrate diet than what other people would be familiar with, because of course that utilizing fat as a fuel source. I mean, we've got hundreds of thousands of calories of fat, even the leanest individual does. And those mitochondrial challenges that you have just described are present regardless of body size. You can't actually look at an individual and particularly know what that underlying sort of mitochondrial health is just by visually looking at them. So I think that's a really important point.
Yeah, absolutely. But the other aspect is, I think, being fit and exercising and moving is fun.
Yeah. Oh, 100%. And interesting what you say about altitude, because I've had a conversation with Professor Grant Schofield about the use of carbohydrate and being fat adapted for a hot environment as well, because a similar thing applies, well, a different mechanism, but glucose use increases in the heat for athletes. However, if you are more fat adapted in that heat, then your reliance on carbohydrate will be less. And so, of course, with people in the longer events, Grant and I were discussing Ironman, where you have to take on board carbohydrate, you run the risk of a lot more GI issues if you are solely relying on this increased glucose demand. Whereas if you work on getting fat adapted, you don't have to rely as much on that glucose. So that does offset some of those gastrointestinal challenges that some people can get.
It's a great topic, Mikki. And, I have to give credit to Sven Bream, who most people may not know about. And he's actually an IT engineer who's really taken a deeper dive into metabolic health. And he's actually helped me work through this whole topic of fueling performance at altitude. And I don't think you're on this email thread, but there's a great thread. Professor Noakes is on that thread. I don't know if Grant is on that thread. He may be. He may be a stalker, but a quiet stalker.
Yeah.
But just having lots of great conversations about exercise, performance, and fuel.
Yeah, nice. And of course, performance is something which a lot of competitive athletes consider and spend a lot of time thinking about. But, we're all athletes, we're humans. So I think that it's really relevant to anyone that is interested in health and well-being and longevity.
Right. It doesn't matter your size, shape, or age. Just being active is important for everyone.
Yeah. Jeffrey, I really want to chat to you about Low Carb Denver. But I do have a question that might lead on to it, actually. Your discovery that the low carb diet was not necessarily the diet for everyone, or a high fat diet, actually. I think I'm going to frame it that way. Was that a surprise? Has your approach, is this something you learned over time, or is that something you sort of knew already? So how has your approach changed, if that's the major change and only change, over the course of the 25 years?
Yes, I've learned with my patients. And I was initially puzzled because I was seeing these types of individuals, and actually talking to the community, I would get feedback, oh, just put them on a low carb diet, just, keep going. And it just didn't make any sense to me, and looking at mechanisms and so forth. And so, over the years, I've learned, I've shifted. And so some of the general principles that we already talked about apply. And it is a great segue into the conference, because the theme of the conference is, where is nutrition headed?
Yeah, nice. Yeah. And of course, one of my faves, Lane Norton, is going to be speaking at the conference. And I believe that raised a few eyebrows, potentially, not amongst the people who know you, but maybe in other people who are attending a low carb conference. Or maybe it was Lane's followers were like, hang on, mate, what are you doing going to a low carb conference? So can you sort of explain what you want to get out of having the likes of Lane at the conference.
So we're delighted to have Lane at the conference, and our our conversations have been very friendly. And so people have to understand that Lane's persona on social media is to insult people.
Yes.
And yeah, and he's the first one to say it, and he's
Totally.
insulted a lot of people. I mean, he's picked on low carb a lot, and so his point about that is, and I agree that people have to be careful what they say on social media. You can say whatever they want; it's not filtered, and is what individuals are saying evidence-based or not evidence-based? And so, what makes social media fun is that there is a dichotomy, that there's, I mean, in medical research, it's that way too. People, there's the two factions fighting with each other. And so, Lane's part of that, but you have to understand that Lane does agree that in some individuals, low carb diets are beneficial. His perspective is that you want to find something that's going to work best for the individual, that will ultimately help control appetite, so that they'll eat less. But at the end of the day, for Lane, you have to reduce the net calories.
Yeah.
So, but it's not. But he agrees that hormones do play a role in it as well, and that it's different for everybody. And so, he was very open and excited to come to the conference. And I think, once you get past the part of him insulting people, and he's toned it down over the years.
Yeah.
So, and I think in person he's very professional, and he loves educating, and he's very fit. And I think that he's going to add to the message and what people are going to get out of the conference.
Yeah, awesome, Jeff. And so, can we have a chat about some of the speakers, or a brief sort of rundown on some of the people you're most excited about? Not that you're playing favourites, but because I understand, obviously, you can be lucky enough to be there in person, but of course, you've got virtual tickets as well, so people can just sign up and enjoy the conference from the comfort of their home. Amazing.
Yeah, so I don't know where, if your audience is predominantly based from your part of the world, but again, there's going to be virtual access to it, and that includes educational credits virtually, or you can, come to to Denver. It's usually just two flights, one long flight and one short flight.
And that long flight's not even that long, 12 hours.
Yeah, it's not so bad. You just hunker down and go for it. But just to summarize, not to really mention people, but you can go to our website, Low Carb Conferences, and see the schedule. But general topics. We're going to look at best diets based on metabolic health, and we're going to look at hormones and calories and nutrients. Another big area is going to be fitness and muscle-centric health. Actually, Gabrielle Lyon is one of the speakers who's going to get into that. I think Thomas DeLauer also get into that. We're going to get into male and female health. We're going to look at eating disorders. I think that's kind of an elephant in the room at the conference.
Yeah, interesting.
It's really interesting because you got to be careful. You don't want to enable people with new dietary approaches that are going to fail. So you have to be careful with that. We're going to look at mental health and metabolic health. This idea that mental health or brain health is just part of again, metabolic disease. And we're going to have a couple talks on that. We're going to talk about intermittent fasting. Nina Teicholz will be there talking about politics and nutrition. We have a whole section on Saturday morning devoted to heart disease. Sunday afternoon, we're going to actually breach or discuss the topic of lipedema, which is another condition that we see in individuals. And so, that's a quick summary.
Yeah, that's a great summary. There are so many super interesting topics, Jeffrey, and like everything that you mentioned, I'm like, oh, that'll be interesting. I can't wait to hear more about that. And of course, it's stuff that we might read about and consume often because we're interested and we do research and talk to people and follow things on social media. But it seems like a bit of a one-stop shop, if you like, for sort of the state of where we're at with regards to a host of some of the most important health conditions that people are experiencing.
Yeah. Well, I know you're coming along with our friend James. Maybe you can entice a couple more Kiwis to travel.
That would be amazing. And I mean, to be fair, the flights weren't that expensive and it's not that long, and you need something to look forward to because, of course, post-February, we're headed into autumn and winter and it's all just a bit depressing.
Yeah. And it's been 3 years since we had the event, and, it's still somewhat uncertain, what's going to happen. But my wife and I, she helps plan the event, and I have some co-organizers. We sat and went down and we said, look, we want people to meet in person, get back together after going to Metabolic Health Summit. It was a really good vibe. And so we decided to take the plunge, and it's going to be a fantastic event. And we really need, the audience to fill the seats. And so the contribution for the audience is in a sense, if they support our event, they're supporting nutrition science, and that's what we want to continue to offer.
Yeah, absolutely. And it's that, the more people that are there consuming the information, just the more awareness people have of these concepts, because, as we talked about, it's unlikely that any real change is going to happen from the top down. So it really needs to be at that grassroots level, people sort of consuming and then trying it on for themselves.
Yeah. And what's unique is that we have a diverse group in terms of knowledge attending. So it's we have the most knowledgeable to the least knowledgeable. And often I joked, the least knowledgeable can be the healthcare professional. They need to be at this conference, and we all learn from each other.
Yeah, totally. Awesome, Jeffrey. So where can people find out more information about Low Carb Denver?
Yes, simply visit lowcarbconferences.com. You can find us on social media at lowcarbconferences.com. Also, Jeffry Gerber, MD. I spell my name funny, Jeffry.
Is that you or your parents?
My parents.
Yeah.
We blame them.
I blame mine too. And of course, I don't want to leave without mentioning your book, Eat Rich, Live Long. It was only, you said several years ago, it was only actually almost 5 years ago now, I believe, Jeffrey. Like, brilliant recipes, really good guides, some food plans to help get people sort of started along the way. I imagine along the same vein as what we're talking about.
Yeah. So in 2017, we wrote it with my engineer colleague, Ivor Cummins from Dublin, and it's still relevant. We're very proud of the work. I was more of a consultant, and Ivor just is just fantastic with language and writing. And so I was by his side the whole time. And also, my wife, Nicole, says hello, by the way.
Oh, hi, Nicole. Oh, I'm looking forward to seeing her. That's fantastic.
You haven't seen her in a while.
No, it's been some years. Jeffrey, thank you so much for your time. And I do really encourage anyone that is able to actually consider going along to the conference. I mean, I say consider, I mean, those of us in New Zealand and Australia, like, it is such a good ground to meet like-minded people. And it's really, there's nothing so satisfying, I think, to actually being somewhere in person. It's just so different from being online. However, the information is available online, and there are a wealth of awesome speakers in the lineup. You've just got some of the best of the industry, Jeffrey, so congratulations on that.
Oh, thanks, Mikki, and we're looking forward to seeing you and James in person.
I don't doubt that you enjoyed that conversation as I did. And next week on the podcast, I bring to you my interview with Dr. Jose Arita, who is an exercise physiologist from Liverpool Moore University, all about low energy availability and within day energy availability. Until next week, though, you can catch me over at Facebook at Mikki Williden Nutrition, over on Instagram and Twitter at Mikki Williden, or head to my website mikkiwilliden.com, where you can book a consultation with me, sign up to my recipe portal access, or of course Mondays Matter, and that kicks off Monday 6th of February, the Shreddiary edition. All right team, have a great week. Speak to you soon. Bye.